Nope. I swear, if I could only get the tech of this down. All right. Hi there, my name is Mitch Stripling. I'm an emergency manager in Brooklyn, and this is my Apocalypse Prep COVID-19 rundown. Due to ongoing technical difficulties, we're going to see how this goes. Somebody hit me up if they can actually hear me. I've reached the fried chicken stage of my own social distancing experience, which means it's getting pretty bad. Bad enough that everybody out there is talking about reopening America, from the president to the governors to your mayor to probably your neighbor, your dog next door. Everybody wants to talk about that. So let's talk about it tonight and unpack those plans. So here's what I want to do. I want to spend a few minutes, and if you've got questions, pop them up in the chat and we will get to them. I want to talk about sort of the plans we're looking at to reopen the country, right? Whatever that means or doesn't mean. And then I want to just flip the narrative and talk about why they're all sort of, although well-intentioned, misguided, and that the key is really in the sort of assumptions that are buried in all of them in different ways. And some people are doing a great job of telling the story. I'm not saying that, but in terms of the plans themselves, we need to stop thinking in terms of transitions to reopening and start thinking in terms of building capabilities. So let me just start off with kind of an explainer, and it might as well start off with the big one. Even though it's only really 6 pages of bullet points, the White House's Reopening America plans, at least as an example. So if you look at the actual plan, it is being touted as, let's reopen the country May 1st. It's not that crazy. It is, the idea of it is that it starts at May 1st, and then it puts in place a set of gating criteria, and then 3 steps, 3 sort of phases that you would do that with. So first, the gating criteria that we're talking about in this case for this plan is that number of ILI goes down for 14 days. That's one. Influenza-like illness symptoms are decreasing. Second, cases are going down. And third, you're able to treat all the cases you've got, and you're able to protect healthcare workers. So then if you've sort of got that, and those are the only gating criteria that are there, and we'll talk about why that's a problem in a minute, it goes into phase 1. And if you go into phase 1, that's a similar sort of situation to what we're in now. But you're minimizing non-essential travel. You're avoiding socializing in groups of more than 10 people. You are doing masking. Vulnerable individuals are sheltering in place. You're doing telework. You have closed common areas, all these kind of stuff. I don't need to read the thing. It's similar to what we're doing right now. And the idea is then, if you go 14 days, and for those 14 days, your cases keep going down, then you hit another gate. And that gate takes you into phase 2. And in phase 2, you are able to start opening some of that up, right? Favorite thing, forgot to say this about phase 1. Phase 1, schools stay closed, bars stay closed, limited movie theater attendance is possible. So it's a little different from where we are now. In phase 2, schools are allowed to reopen, but people are still telecommuting, right? So you can see how we're going phase 1. You loosen it a little more to phase 2. If you stay then again for another 2 weeks in phase 2, you get to go to phase 3. And in phase 3, people can start going back to work. People can start staffing their employment sites again. So essentially, if things continue to go down, in 6 weeks, you get to the point where you're staffing workplaces. So the thing about this plan is that it says at the very top of it, under the things states are responsible for, a couple of things. It says that states are responsible for testing, contact tracing, healthcare capability, and being able to protect the health and safety of workers. So, just that those little things that are there. So a couple of questions out of the way. Why is it 14 days? That's the basic incubation period of the virus. So the theory of the case for this plan is that in 14 days, you can tell whether things are going to go up or down, and then you can adjust. Now, let's look at the big problem with this plan, which is that within those 14 days, once you see a spike, that spike can expand, right? And the lockdown doesn't help, because if you see a spike within those 14 days, those infected individuals exponentially will infect other people. And so essentially, in that 14-day window, you can start an exponential acceleration that, again, you're going to lose control of. That's the problem with a 14-day gating period. Okay? All right. So that's kind of my explanation of that plan. We can go into that more if you want. Here's the problem with it. And here's why all of these pieces people have been sending me are important but insufficient. The Times piece or the Ezra Klein piece, all these things. We are treating the coronavirus as if it were a unique incident in history. And it's not. It's something that actually has been very common throughout history, except for recently, right? It's only recently that we felt that we were in control of these viruses. And because we felt that we were in control of these viruses, society has lost a set of muscles that it has had before, and that now it could have better in the future. So my argument for you guys, if you're listening, is we need to stop thinking of this as a situation that is going to switch on or switch off, and start to think of it as, unfortunately, a world where the coronavirus exists. It's not going to go anywhere, and we have to build a set of muscles as a society to fight it, and start focusing our plans and capabilities on building that set of muscles. In emergency management, we have this thing where you don't actually plan for a specific scenario, right? You plan for a set of capabilities that you need, and by building those capabilities, you're able to respond to a number of different scenarios. We knew 10 years ago, 15 years ago, this was coming. So for me, this is like watching a movie where you already know half the plot, although I didn't see the memes coming, and I didn't necessarily see John Krasinski happening. I mean, who saw that coming? But anyway, what we need to do is focus on building a set of capabilities in society. And a number of people have pitched this. Tom Frieden did a good job of this from Vital Strategies in the Zoom and the papers he's written. A number of people have proposed parts of it. I'm going to kind of summarize the key aspects of what we would have to build to make that happen. So first thing is testing. Everybody's talking about testing. We have Abbott machines. We have reagent supply shortages, all of this kind of stuff. As a baseline, for other illnesses that we've tried to control, we've had to go into a mass testing environment. So I think right now we're able to do tens of thousands of tests a day. We're going to need to go to something like, some scholars from Harvard are saying sort of tens of millions of tests a day. So why are we doing that? In public health, you really are only testing for two reasons. You're testing to figure out how widespread an illness is, and you're testing if the results of that test will change clinical treatment. For the most part now, the test isn't changing the clinical treatment for COVID. And right now, I'm continuing to say, if you can manage your illness at home, do not try and get a test. There's no point of it for you. But in the future, in order for us to figure out how widespread this virus is, we do need to build it and put in place a widespread testing strategy. That's why these fights between the president and governors, where the president is saying there's nothing wrong with the test, are so infuriating, because the supply chain of something like reagents, which are an international sort of supply, right, are something that the federal government can really help with. So we've got to find ways to surge testing. Now, that's what's very much on the minds of everybody, but it's actually not the most important thing. The most important thing from a public health standpoint is something called contact tracing, which you've also heard a lot about. People are fixated on testing because it's like magic and it's technological, right? And if you can get a little strip of paper, a little light laser in your ear, and you know whether you've got it or not, it provides comfort. But it's actually not the most effective thing that we can do to control a virus, because testing is always chasing after the virus, right? It's always a lagging indicator. On the other hand, a lot of the plans are saying that we need to start, before we can get to gating criteria or whatever, we need to be able to trace all of the contacts that folks have. So when you're sick, every person that you walk past, every person that you associate with is a potential contact. They're a potential person that you can pass the illness along to. In China, every COVID-19 patient had about 45 contacts. That's a lot. In this country right now, there are only a few thousand contact tracers in total. Some of the estimates are that we would need an army of like 300,000 contact tracers around the country who, for every person who was symptomatic or who tested positive, would swarm the relationships of that person. They would trace all of those contacts, and they would look and they would test those contacts to see if they had COVID, and then they would work with those folks to isolate them, right? Now, the thing about something like that is you think, oh, 300,000 people, that's a lot of people. How are we going to do that? But we're in a scenario where millions of people are out of work, right? The Peace Corps has been shut down. There are all of these folks out there who are looking for a mission. And contact tracing is not that technical, right? It is something that you can learn. You're going to go out, you're going to interview people, you're going to track them, you're going to help them check their temperatures. Anybody can do that. So I wish that instead of focusing on gating criteria, we were focused on a widespread federal strategy to build an army of contact tracers to start encircling every symptomatic individual and making sure that they were isolated, making sure their contacts were quarantined. That's something where you really need a federal push because you've got to unify it across states. It does not require sophisticated technology. It just requires human power and human connection. It is totally doable, but we need a group of leaders who can get the ball rolling on it. So it leads to this other musculature, which is uncomfortable for us. The single most important way to contain an outbreak is not closing down bars or shutting gyms or telling people not to go to the movies. It is making sure that anybody that gets the illness isolates themselves. Anybody that might have the illness isolates themselves. That's why the very beginning of this, if you can remember all the way back to March, like 6 million years ago, was that if you were a contact of somebody who had COVID, you had to go home for 14 days. That is the single most effective public health strategy to get us out of this. Again, there's not a lot of technology there. The problem is people won't do it. That's where I'm going to drink in my drinking game. I'm going to drink to the human failure to follow public health rules. So people don't do it because we all feel that we're like unique, right? And that we probably don't have it, and we really need to do this really important thing, like go to the grocery store or play with our band or play poker or something like that. So in China, right, what they did was if you possibly had the illness, they sent you to a camp. Sometimes it was a nice camp, sometimes it was kind of not a nice camp, and they made you stay there until they determined that you weren't symptomatic. There are a lot of legal problems with that. There are a lot of civil rights issues with that. But if we could find ways to isolate people who were contacts, that's the way that we could control these outbreaks once they happen. So I'm going to hit two more things, and then I'm going to circle all this up. And if you've got questions for me, feel free to pop them in the chat while I'm ranting. The next thing is we have to make sure we're protecting our healthcare workers. That's why this lack of PPE problem, the masking thing, has been such a tragedy because, again, it doesn't require technology. You know, if I'm a leader in this moment, I want to focus everybody on high-tech testing stuff because it disguises the fact that the bread and butter problems of this were much more low-tech, right? They're made out of layers of fabric and rubber, making sure that people had this protective gear. So we have to find ways to make sure that healthcare workers get the first tests, they get the first antibodies, they get the first safe treatments, they get the first safe vaccines. If you are a frontline healthcare worker, that is where our force and effort need to go to make sure that we can treat cases that are there. And finally, that leads us to treatment. Everybody's focused on a vaccine. Fun fact, the world record speed from start to stop in terms of getting a vaccine out to the public was the mumps, and that vaccine took 4 years. So it is likely that we are going to see other treatments before vaccines, right? We're going to see some of these antivirals work. We're going to see some other drug combinations of work. Look at something like HIV. We're only just getting to the point now where there's something that is sort of like a vaccine. When you do PrEP before, you can keep from getting it. But for 20 years, we've had antiretrovirals that, used in combination, help people live through the disease. That's probably what's going to happen first. So what am I saying? Let me kind of wrap it up in a bow for everybody. It is useful for us to have triggers and gating criteria to tell us when to sort of restrict society and when to let it go. And it is possible we'll have to use those more than once as we go through this, because we need to be able to move from phase to phase, from trigger to trigger, to kind of lock things down when an outbreak scales up, and then release as that outbreak scales back down. That's reasonable. In New Zealand, they have 4 clear sort of levels of lockdown already in place. People know what level they are. It's not like the mass Wild West chaos we're living through in this country. That's good. But it isn't the most important thing. The most important thing is the country building a set of muscles to deal with diseases like this. And it's a set of muscles that we've forgotten about, but that in the 1920s, the 1910s, those sorts of muscles were really in place because these sorts of viral outbreaks happen faster. And for the most part, they do not require high technology. They require the use of a lot of human power, and they require the sort of strict following of a set of principles and being willing to isolate people. If we could do those things well, then it makes a lot of the gating criteria much less important. Because at the end of the day, whether schools are open or closed, it's important. And we don't know a lot about it. We still don't know how much kids are carriers, but it is not as important as isolating the contacts of ill individuals. It's just not. So if we could do isolation well, we could spare ourselves a lot of the pain these other things are causing us. I mean, bars are closed. That sucks. Who wants bars to be closed? And in the Trump plan, we don't get bars back until a little bit in phase 2 and then in phase 3, although we get gyms back in phase 1. So, I mean, that's nice because it means we can all sort of get more in shape without the alcohol and the heavy foods in the restaurants to keep us back down again. So my point is, the Trump plan has these underlying assumptions in it. These underlying assumptions about being able to test, being able to isolate, being able to contact trace, being able to treat. And it's those underlying assumptions that are really the important thing towards keeping you and your family safe. And it isn't just Trump, unfortunately, right? Most political leaders, because they think in these kind of social requirements, this is where their brain's going. But in fact, surging the capabilities and the resources is going to get us where we want to go faster. Noting that, yeah, this is going to be a long haul. Right now, COVID-19 is killing more people per day than heart disease or cancer, which are the 2 normal leading causes of death. But I want to be clear, heart disease and cancer still kill that amount of people every day. As a society, we've come up with a set of ways to manage that we feel okay about. And so the thing to do for COVID is not to shut ourselves down forever. It is to do that and do it well right now and do it strictly while we build this set of muscles to deal with it over the long term. So that is my rant about reopening. So if you've got questions for me, feel free to hop them now. I got a couple that I'm just going to hit. So Kip is saying, you feel like you can't afford it, and in reality, you can't afford not to do it. This is you can't afford to isolate yourself. That's what people are thinking, and the reason is because we don't have a set of societal incentives that make it okay for people. Right, we're starting to build just the barest sliver of those right now. Right, this thing about COVID-19 sick leave. It's okay, stay at home for 14 days. But in reality, we've got to make that a default no-brainer immediately, and it may have to be longer than 14 days just because we're not ever sure sort of what the connection points are. So that's That's an important one. We don't have a set of muscles in our society that made this stuff easy or clean for people. That's why other countries, Germany, even as an example, New Zealand, Ireland, are putting in place aid packages that aren't sort of everybody gets $1,000 or something. They're aid packages towards the denominator of what is the need to get the job done, right? And that's what we kind of need in this moment. All right, getting a shout out from Richard Hopkins there. Yeah. So, what Richard is saying is the way to prevent cases is strict supervised isolation of infected people and identification of all contacts, testing of symptomatic contacts, and strict quarantine of contacts. So the thing about that is the definition of strict. And the ethical question there is, how far are we as a society willing to go? Are we going to put people in camps like in China? Epidemiologists are very divided on this issue. We have found one thing that health departments have found in the past few years is, and we did this with Ebola, in areas where you can get symptomatic people to care quickly, sometimes doing active monitoring of folks is as effective as isolating people in camps. For one thing, it's much more easy in terms of logistics, but instead of building like an entire new sort of resort for quarantined individuals, you can have nurses or public health workers assigned to call them multiple times a day, do virtual temperature checks, and do those sorts of things to make sure people are isolating while respecting their civil liberties. So, that's really the end of my rant. So let's hit some questions as we go. So Jesse is popping. Jesse, let me show you my fun new toy. Jesse is asking if I have any thoughts or educated guesses for timeline or maybe timelines depending on certain factors. So the summary of what I was talking about was that we shouldn't think of this in terms of reopening based on a set of criteria. It's more effective to think about a set of capabilities the country needs to build up in terms of the ability to test, the ability to trace contacts, the ability to treat. The issue is that unlike closing or opening the country, which you can do, drop of a hat, apparently, those capabilities take time and they take national unity. And that's something that it's really hard to predict. I think that it is possible, and I think that under other administrations, it would have been likely that we could build a lot of that musculature, at least in an improvisational scale, within a timeline of a few months. None of those moves are happening right now, which is so inexplicable to me. I've lost the ability to pronounce things because what all the models show, and all the models are wrong, right? Let's not rely on any model, but all the models show that when you do gating criteria like this, you're just going to start a roller coaster. You're going to start a roller coaster of you're going to turn them on, you're going to turn them off. Because you're not focusing on contact tracing, somebody will always slip through. It'll always cause an outbreak. It'll always cause a panic. Then you're going to have to shut everything down again. And you will have to do that until you have a vaccine. Go back to my earlier point that the fastest vaccine on record for mumps was 4 years of time. So let's all avoid that. So anyway, the factor that we need is a comprehensive national strategy to build an army of hundreds of thousands of contact tracers who are able to wield tests and the ability to strictly isolate cases in their contacts. That is what we need. And none of that requires high technology or even Google and Android getting together, although God love them. I think that's a great idea. It's all sort of human power and commitment. So it's astonishing to me that we are not doing that. Question from Ben. At what point will antibody testing be available at scale? What is the estimated seroprevalence of CV-19 in highly affected areas like New York City? Oh, I love this question because we're getting wonky. I've read estimates of less than 1% up to 10% based on small-scale tests in Iceland, Germany, and Santa Clara County. Okay, it's handy. I've got that here. Let me see if I can find my page. Because I'm like in one place all the time, I've gone back to paper note-taking, which I haven't done in like 15 years, which is good a lot of the times, but sometimes I can't find it. Okay, so here's the problem. There are two parts to the question. At what point will antibody testing be available at scale? At scale. So it depends on what at scale means, right? First, what we want to do first is to be able to give healthcare workers antibody testing. For people that don't know, when you're testing for antibodies, you're trying to test if a person has had COVID-19. Their body has an immune response. It builds up antibodies. You test if the antibodies are there. You can assume A, that they had the disease, and B, maybe that they're immune. So just to take that part of the question, we don't actually know that that's true. And the WHO this week actually came out with a statement saying, hey, listen, it is not, there were two parts of the statement. Hey, listen, it is not true that people with antibodies are immune. Nobody's proven that. Don't go around saying, Britain, that you can give somebody an antibody certificate and you know they're immune. Second, some studies in China are showing that some cases of COVID did not actually build up antibodies. That is, even when they had it and tested positive, testing them later, they did not build up antibodies to it. They did not have the appropriate immune response. So that's a major mystery to this. That's one of the reasons that this is so uncertain. So even if there were an antibody test, we would know that a person who had antibodies and had COVID, we would not know if they were immune to it, at least not yet. So the scale question goes back to this question about reagents. And there are a couple kinds of testing we're looking at. It's like, how wonky do you want to get? Most of the testing we're talking about right now is PCR testing. You're testing for viral RNA that shows up even if it's dead in the body, and that uses reagents that are like little pieces of RNA that are spliced together, and those pieces can, boom, oh, look, there's a matching RNA. That's how you know you have a positive test. Serology is a blood test that tests for antibodies. It takes longer to do. It just takes longer to run, and it takes longer to design just because the human antibody response takes longer. So we are a number of months away, and the dependency is not the test, it's the supply chain, as with all of this. In part, when you're doing serology, you've got to make sure you've got things like syringes and some things that we're not looking at supply chain now. I only answered half your question so far. What's the seroprevalence? So the big reason this is important is because we need to know how many people have had COVID. So as Ben is lifting up in the chat, there are a number of studies on this. Looking at the country, the studies in this country are saying that it is possible that between 3% and 10% of Americans, not just people in New York City, 3% to 10% of Americans might have had COVID already because of the high number of asymptomatic folks. That's like 30 million people out there. And that's because we don't know how many people have symptoms. Some of the studies in China started out saying that like 5% of the people didn't have symptoms. Some of the later studies said that up to 60% of the people with COVID might not have symptoms, and nobody knows. So you can't design any good math around this because the uncertainties are too much. I've seen models that say that maybe 30% of people in New York City could have had COVID already. That is a magic number. That is why if we could do widespread testing over a sample size population, Santa Clara County is pretty small. In places like Colorado or Iceland, you're showing high seroprevalence. If you can show that like half of the population's had it already, you're getting close to herd immunity, and you're getting close to herd immunity if people are actually immune to it, which we don't know. But it changes your outlook because you know it's spread around. You know that it's really asymptomatic. So I'm talking around your question. The answer to your question is, in New York City right now, there are a lot of different sort of current models, and they range between maybe 5% of New Yorkers up to 50% of New Yorkers. And because we don't know asymptomatic cases, and because we have of this lack of testing, there's this big hole in the middle of the models. And that's why anybody who is showing you a curve or a model of this going forward is selling you something, except to say that there will be another uptick in the future. That will happen. But anything beyond that is selling you something because we don't know the number of asymptomatic cases. All right. So the question from David is, who makes the tests? Could you not just sell them? Many would pay good money for them. That is true. And the situation we're in right now, a couple of things. First, you never want to do tests based on who can afford them because they're going to get bid up, and it's going to become like like pop art or something. People are going to pay millions of dollars for like 5 tests, put them in your pocket, and then you're going to see poor people die en masse because they can't get access to testing. The issue is a couple of things. The issue is that there's a supply chain issue around the reagents in the test, which is to do the test, you actually have to develop these viral kits that the virus reacts against. So there's a problem in the supply chain for it. That supply chain is getting pulled on by everybody in the world, and because of that, it's not scaling up fast to meet the need. And in New York City, we actually saw that even the swabs, like the nasal swabs that people have to jam all the way back in your airway to take the test, we're running out of those swabs. So there was one day New York City could only test 25 people. It was going from thousands to just 25 because we just ran out of that. So a lot of this is baseline supply issues that we were not stockpiled for something like this. So Beck is asking, because our leadership isn't in place to create this scenario you recommend, what should a high-risk person do once state restrictions are lifted? Not go to school or work, avoid large crowds, live life, but wear a mask. So let me take those in reverse order. If you're a vulnerable individual, just to be clear, surgical masks, cloth masks are not going to help you, right? They're to keep you from spreading the virus to other folks. So one issue would be, it would be great if we could get to a point where we could have PPE, not just for healthcare workers who need it most right now and they're the priority, but for other vulnerable individuals out there who often are recommended to wear face masks N95 by doctors for other conditions. So most of these gating criteria and even the Trump Reopening America bullet points have special accommodations and rules for vulnerable individuals. And what they say is that even when you get to a phase 3 reopening, even at that level, I'm trying to find the specific language so I can answer your question. At that point, what they are recommending is vulnerable individuals can resume public interactions, but should practice physical distancing. Side note, look at that. People went from social distancing to physical distancing. Daniel Aldrich, points for you in sociology. Anyway, vulnerable individuals should practice physical distancing, minimizing exposure to social settings where they can't distance unless precautionary measures are observed, which means in practice that for the long term, vulnerable individuals who are adults are being asked to practice social distancing. And it means they would be asked to practice telecommuting, which means, like, for instance, if for a kid, it might mean that depending on how the studies of kids as transmitters pan out, that you might be looking at a time when high-risk kids would have to take school at home for like a significant period of time. Because and each state is doing this differently. If they were to follow this federal model, which is kind of the model most likely to cause like a massive outbreak really fast, so let's not do that. But even under something like Governor Cuomo's model for New York or the California model, vulnerable individuals are going to be asked to physically distance themselves for much longer in anticipation of a potential second wave, because everybody's worried that vulnerable individuals who mix in the populations would become the first casualties of that second wave, which is being modeled to happen anytime between like September and January, and all the models are probably wrong and nobody really knows. But the hard truth of it is that that's the problem, is that if you're a vulnerable individual circulating in a society with no good treatments for COVID, then it's always going to be out there somewhere. So until we have really good treatments, until we sort of know its prevalence, and until we sort of have a vaccine, they're going to be asked to stay physically distanced from other people. Going back to my earlier point, that's why it's so much better to build up contact tracing and testing and treatment and all of these other things instead of focusing on gating criteria, because building that public health muscle would actually help people. It wouldn't just shut everybody in the economy down and leave us all hunkered in our houses. It would let us respond actively to a crisis. And it doesn't even take federal leadership, right? We have all these billionaires now. Let's have Elizabeth Warren wrangle all the billionaires and get them to drop it on us that way. Jesse's follow-up, could we go to Lake Tahoe in July for my birthday? Well, what's a good question? Should we let Jesse go to Lake Tahoe? That's really what this all comes down to, honestly. I don't know. Facebook just canceled all of its large gathering events through next year. I think that we may be in a place governmentally where groups of under 10 people are okay. And in the Trump plan, people can go back to non-essential travel, I think in phase 3, that's what he's saying. No, it might be phase 2. Yeah, okay. So the Trump plan is that when you hit phase 2, which is essential 4 weeks of no up cases, you could start resuming non-essential travel. In Tom Frieden's sort of plan on that, once you had the ability to isolate and trace and all that kind of stuff, you could start doing. I don't know. You know what? I think the answer is no. I think the probable answer is you're probably not going to be able to go to Lake Tahoe. If you have a very small group and there are ways to contact trace it, maybe you can. I don't know. I'm mumbling about it. Maybe I'll do a whole travel agent one of these later. I don't know. All right. Look at that. In Vermont, Richard is saying they're building an army of contact tracers. There we go. So here's a question from Moises. Can you articulate why divorcing this from political debates, attaching profit motive to testing causes new problems along the lines of PPE shortages thanks to compound market-based issues? I think I got that. So the problem is in situations like this, the market doesn't help you. And the market doesn't help you for a couple of reasons. Number one, everybody in the globe is competing for this stuff. And the people who are supplying it have an incentive to hold on to it, right? Like we do not want to rely on China to build all our testing capacity because they're going to decide who to sell it to and they're ticked at us. And also they're going to charge us an arm and a leg. What you want to do is devote the resources of your civilization towards helping your civilization. And actually, if I were Ayn Rand, let's just pretend I'm Ayn Rand and I'm like riding the fountainhead in the middle of a pandemic. The reason even I would agree with this or the libertarian argument for doing that is because the data shows us that if you do that, the bounce back for the economy is much greater because you don't create this long period of uncertainty where people are dying. You create unity. You go at this like it's a war. You build these new capabilities. And then after it, the economy comes back stronger, similar to how it came back stronger after World War II. After the Black Plague in the 13th century, people died off, people came together and worked on it. The economy came back stronger. Not an argument to ever have the Black Plague. But the problem with these market incentives is that they are confusing and they create competition between states and cities when you need unity. Governor Cuomo said something I thought was great when he asked for ventilators and states and countries sent us ventilators. Then he committed to then shipping them out because the way the epi curve works, it's not going to be needed everywhere. So if we have a pact between all states for emergency management assistance, surprise we do, it's called EMAC. So governors can commit to sharing supplies between each state. By doing that, we could have a cache of equipment that would move from state to state for what people need when the curve hits them. That is so much better and much more utopian than all of these states fighting with each other and fighting with FEMA for supplies. All right. Whew. Man, I went into some numbers there. My favorite sort of thoughts actually have been from Vital Strategies, which is this group that Tom Frieden is part of the leadership in. And they've come up with some good sort of criteria and ways to do that. This 300,000 contact tracers in the country was from them. I think that's it. The thing I just want to close, and if you've got more questions, hit them up. Jesse, I promise I'm still thinking about Lake Tahoe because I'd like to go to Lake Tahoe also. I had Disney World tickets before all this started, although I think secretly parts of my family are just happy we're not doing that. So maybe there's a silver lining. Look, the hard truth about all of this is that the death rate is still high and this is not going anywhere. We are not on the downward slope of this. That is not the right narrative. The country may be on the downward slope of the current curve, which is good. But hundreds of people, thousands of people are still dying every day. And there are two parts of that. It's really nuanced, and that's hard. Thing one is this is now going to spread across the country. It's going to go into more rural areas. It's going to go into more Republican areas. So let's make this sort of not a partisan thing. People are going to start dying of it. Places where people have sort of worse health currently, places that are more in poverty, they're going to do worse. And we're probably going to see higher fatality rates per capita, even than we've seen on the coast right now. That's one scary thing for the future. The bigger scary thing for the future is that this thing is here. It's here now. We didn't stop it. It is circulating. It's going to be doing that for a while. We've got to focus as a society on building muscles to fight it, not on like keeping ourselves closed and open and keeping ourselves in the state of fear. Let's go out and wrestle with the thing using the best science and public health we've got. And we have to sort of hold that idea and hold the tragedy of this in one hand. And on the other hand, we have to know that there are other causes of death that this country's wrestled with, heart disease and cancer, that are up there, HIV, all of these other car accidents, all of these other things that we have, they kill a lot of people too. And as a society, that's not good news, right? We don't want those death rates to be there, but we've wrestled with those things, and over time, we've got them under control. COVID's not going to go away, okay? But it is something that with good science and effort and unity, we can make a thing under control and not a thing that is keeping us all up at night all the time. I think that it's possible. I even think that's possible within the current craziness of this administration because of the amount of leadership that's coming from other sectors. All right. Woo. That's probably all I got of me. I want to just see if there are any other questions. I'm going to give folks that are listening another minute if they want to. Okay. Hit me up. I'm increasingly saddened by the kind of racing class implications of this, so I'm going to do another one of these on that. And if you've got other things you want me to focus on, hit me up. Thanks, everybody. Be safe, be well, and love your family. Hope everybody's doing okay. Talk to you soon.